So there we go. Good evening, everyone, and welcome to Care Spotlight. I'm Debra Callender, a physiotherapist who is also a certified dementia practitioner. I hold a master's in dementia studies, and I am the founder of Caribbean. Tonight, we are talking about one of the biggest issues affecting older adults, caregivers, and families across the Caribbean, and that is fall prevention. Tonight is really fall prevention, preventing the next fall before it happens. I'm sure you know about what we call retropulsion, where they fall and then they have this leaning back mechanism. Ever after that, that's very difficult to start. And obviously, all of this leads to decreased independence, increased caregiver burden, and and potentially a family crisis. The good news is that many falls are really not random, even if they appear to be. And many falls are preventable, which is what we want to talk about. They're preventable when we understand the risks and we make practical changes. So I am very pleased to be co-hosting this conversation, and you'll see her a lot more. I'm pleased to be co-hosting this with Dr. Melissa Walcott-Pusey, who is a physical therapist, a doctor of physical therapy, and the owner of Total Therapy Ltd in Barbados. She is a clinical contributor to Caribbean. So you'll be seeing a lot more of Mel. I call her Mel. We'll be seeing a lot more of this. So in these spotlights, and also we'll be seeing contributions to her, from her rather, in the community. So be patient with us.
Thank you very much, Deb, for having me. I'm so very happy to be here doing this one with you, co-hosting it. This is a topic that's close to my heart because, as you said, fall prevention is not a small topic. It's not a small issue, and it really affects patients' independence, their confidence, their family routines, caregiver workout, caregiver burnout, as you've said. And I'm glad to be that you're framing this as a prevention. Because I think very often people are like, oh, you're going to fall, don't fall, and that's not helping. So the fact that we're looking at it more from a preventative point of view, it's very useful, But yes, as I said, there are very often warning signs before people fall. So we really need to start looking for these things, become aware of what they are, so that we can then say, okay, well, why is Granny holding on to the chair more when she's walking?
Right.
She's walking all these furnitures, she's hitting her feet on things, she's having a near fall more often than used to have before, right? Struggling to get it from a chair, or even things like rushing to use the bathroom, because all of a sudden it's like, or becoming unsteady when you're walking with them. They all of a sudden they want you to hold their hand, which is something that never used to happen before. So these are all sort of things that we start taking notes of.
Yeah, and exactly. And let's say it from the start. Fall prevention is really not about telling people things like be careful. That really is not enough.
That does not help.
Yeah, if be careful worked, nobody would fall, right? So fall prevention really is about looking at the whole picture. It is about the person, the home, the caregiver, the equipment, the health conditions that the person has, the routines that are going on in that household, and of course, the environment itself.
Yeah, and what it's not about is stopping old people from moving. And I'm going to say that again, because that is so essential. It is not about stopping old people or anybody from moving, because you don't necessarily have to be old to have fall issues with falling, right?
Yes.
Stability issues, right? Sometimes families become so afraid that they only want the person to sit all day, and in sitting all day you cause more problems because you're going to get wasting and all those other things. They become stiffer, they become weaker, their fear increases, and that then will make them more likely to fall. So we're not trying to remove movement, we're trying to make movement safe.
That's the heart of it. Tonight, we're going to look at fall prevention as a system. We'll talk about why falls happen, what caregivers should observe, the home safety, bathroom safety, nighttime falls, which I know is a big thing, especially for a lot of dementias, dementia itself, poor judgment, walking aids, things like chair height, transfers, exercise, medication, vision, footwear, and pain, and what to do after you have a fall.
Yeah. And we will keep it very practical. Families should leave this feeling with a checklist tonight of things that they can look at tonight or tomorrow, you know.
Exactly. So let's start with the big question, which is, why do people fall? Melissa?
When someone falls, families often look for one reason. They may say she slipped, or he tripped, or she just got up too fast. But most falls are not caused by only one thing. Usually several risk factors come together, and those are what cause the fall. For example, someone may have weak legs, there's poor lighting, there may be a loose mat or a low chair. May have urgency to go to the bathroom, so they're actually rushing to get up and trip on the mat. Their blood pressure may drop when they stand because if they're on a new medication or the medication might be too strong for them. Any one of these things may not cause a fall by itself, but together they create a risk.
Yes, I often think of fall risk or falls and how they happen as a stack of small risks. So if you remove enough of the small risks, the overall risk goes down. So a fall can involve many things at once. So many things can be driving the fall: muscle weakness, poor balance, pain, dizziness, poor vision, medication, side effects from the medication, unsafe shoes, slippery floors, clutter, poor lighting, unsafe transfers. So how we get from place to place, are we doing it in a way that is safe and stable for the person? Are we rushing? Is the person confused? Do they have poor judgment about? I usually talk about things also, and I think we'll come to that later, about things like depth perception as well. So poor judgment in terms of, am I able to make this transfer, for example, but also poor judgment in terms of, am I, assessing depth properly? Is this a step? Can I see that it is a step, or am I just looking at it as am I assuming it's a level floor surface? We talk a lot in dementia about putting a stripe of contrasting tape or having a contrasting edge for the step so that the person can see the difference between the end of one step and the beginning of the next one. So depth perception, all of those things can really, really cause a fall. So, if it is that you are thinking that, fall prevention is just about one thing, it's a very, very, as Melissa said, it's a very, very broad topic. And there are lots of factors that we want to sort of bring together.
Yeah. And, the person's diagnosis really matters. A person may have had a stroke, which means that they have weakness on that one side. And it might not only be weakness, it might just be that they have a poor awareness of that side. So they feel that they're pushing out, but they're really not pushing out, right? A person with Parkinson may just freeze. So they might think that they're moving, but they're not actually going anywhere, right? Or they may shuffle, or they may have difficulty turning. So they know they have to walk 5 steps and then turn right to the bathroom, but they just can't get that turn in. Yeah. Someone with arthritis may avoid putting weight on the joint. So, my ankle is hurting me tonight, so I'm limping a bit. And that limping, I trip up on a mat. It's a combination of those things, right? Someone recovering from an illness or hospitalization may be much weaker than the family members from before they went into the hospital. Right? And so they can no longer take those steps, so they require more care to be able to do things that before they left home was really easy. And I think people believe that you need to be in hospital for a long period of time for this to happen, or to be immobilized for a long period of time, but it happens very, very quickly.
Very quickly, especially in older people. That same idea of what I was talking about, retropulsion, which is leaning back when you're trying to stand up. That
instead of going over tees,
yes, that happens with the hospitalizations, because you are lying down, and a lot of people preferentially, especially in our cultures, they preferentially want to nurse an older person lying down. The person might have been hospitalized because of a fall and awaiting, like diagnostic. So they nurse the person lying down. And that tendency we have to have the person lying down, it really does mess with our amygdala, and it messes with the brain's ability. It shifts the brain's perception of what is, and in older people especially, that does happen regularly. You're completely right. In dementia care, the fall prevention has an added layer. You know, a person may not be able, as we've spoken about, to really judge risk well. They may forget things like the fact that they need help. This happens very often for my patients. They get up without calling for help at all. They might forget that they should. They may walk to the bathroom at night and have an accident. They may use furniture to kind of navigate along inside. And not just dementias. We all see this, where they're using the furniture to navigate along it instead of.
I'm always teasing patients that they're exercising the furniture more than they're exercising themselves.
And they also may just be restless in dementia, agitated, or feel like they're looking for something. I had a dementia who had a fall because her grandniece was playing and her toys were scattered out. And the person living with dementia, she was trying to get up to pick up the child's toys. And had a fall, you know. So fall prevention in dementia is not just about strength and balance. It's also about supervision, what kind of routines we have, the use of things like cueing and redirection, and also environmental planning. We need to plan our environment, especially, I would say, for all other people, but especially with dementias.
Yeah. I mean, and what's important there is that most families will say, but I told her not to get up. I told her to sit down and wait, right? Why did you get up? But if the patient has dementia, she's not going to remember you told them that. She's not going to remember to wait. Feels like she's the person that's, I've been calling you for the last 5 minutes, even though it was only called once. Right, maybe. So we actually have to change the way that we set up that safety is built into our household and into our routine and into the things that we do, right? You know, so that it becomes second nature.
Exactly. So our first takeaway would be, do not treat every fall in the same way. You have to look for the reasons behind the fall. If someone falls once, that's not just one of those things. You know, and it tells us that we need to review what has happened and look at what can be changed. So, Melissa, let's talk about what families should ask after a near fall or a fall, because this is where I think a lot of fall prevention can start.
Right. Well, the first thing we need to do is take away the blame. So it's not like you fall and you're quarreling and you get all, take the emotion out of it. Right. Yes. I know we feel guilty, but, we just really have to, and they feel embarrassed. So if we keep the emotion into it, we'll never figure out what is wrong, and it will happen over and over and over again. Right. Some useful things to ask is, what were you trying to do? Where were you going to the bathroom? Right? Were you reaching for something? Were you trying to answer the phone or the door? And that's a big one, right? Because a lot of us have portable phones, but or even cell phones, but instead of having them right next to us, they have them a mile away.
Somewhere on the counter,
yeah, somewhere on the counter. So, if you realize that that's it, you bring the phone closer, right? Were you trying to answer the door? Right? Were you dizzy? No, that's a big one, because if your vestibular system is shot or your blood pressure dropped and it gives you that dizzy sensation, you really can't stop yourself from falling. And that's something we need to take up with our medical professions or other people who are on the calls with us. Were you in pain? So did you stand up and then you were in so much pain that you had to sit back down, right? Was the floor wet? And most importantly, was the lighting, how was the lighting? Was the lights off? Were the lights on? Little things like dusk to dawn lights make a big difference in a hallway when you have somebody who forgets to turn on a light.
They do.
Right? Did you have your walking aid? Was it nearby? Did you remember to use it? Right? And what sort of shoes were you wearing? Were you just wearing socks?
With a lot of our older people, oh my goodness. That sock thing.
It's a sock thing. But you can get, in a situation like that, Yeah, but you can get the socks with the grips at the bottom. So if you know that they're going to get up
At
with
the
socks all the
bottom.
time, so you want to wear socks, let's go with these ones. You know, there are options
Right.
and
The
there are
ones that have
alternatives.
the grip on the bottom.
They're
Yeah,
really
no.
great. Yeah.
No, and we see I see a lot of it in Jamaica where they put on the sock and then they put on the slipper, and you're like, this in an older person, like the combination
It's
of
trouble.
the slipperiness of the sock and then a slipper that there's poor control. You know, the slipper is not attached
It's
to your
right. It
ankles.
doesn't have a back strap. Right. So
Oh
your foot is
my
going one way,
goodness.
the sock is going next way.
Going the
Like,
other way, and your balance is already
mhm.
compromised. Really crazy. So
Yep.
the
Yep.
questions you've mentioned are really, really useful. I would say another thing to ask is what time of day did this happen at? Because falls also
Right.
often have patterns, which a lot of us might not know. Some people tend to fall at night. Some fall when they're doing something like getting up from a chair or in the bathroom. The bathroom at home is the most common site, I need to say that, of falls
Mhm.
at home.
Mhm.
So if you take nothing else from this, have a look at your bathroom, because the bathroom is the most common site in homes for anybody to have fall, not just older people, not
Yeah.
just dementias, anyone. Some people,
Yeah. And
again,
it's the bathroom mat thing, right?
can be the bathroom mat, can be the tile, can be again to do with color, right? And can be to do with how the person does things in the bathroom. So
Right.
some of the older people are also stiff, and other things that we've talked about in other lives, like if your bathroom seat is low and you
Right.
haven't mended that with the toilet seat raised, a lot of falls happen getting up off of the toilets where there's not another grip, and you're trying to get up from like a low seat, or you just tumble forward or tumble over to the side of the seat.
Over.
And often in our, between like the bath and the toilet and stuff. And of course,
Yeah.
and of course the bath itself is really slippery. So that there's just a lot of potential. And as you said, also the rugs, and what the rugs look like if your rug is the same color as the floor, or your rug is
There's no contrast.
Right. So that you're stepping and you're not realizing that you're stepping, onto a mat, and you know, like your foot might go under the mat and stuff. So there is just like a plethora of
Things in the
opportunities.
bathroom. Yeah.
And moisture makes it worse too, right? So look for the patterns, as you were saying. Some people, are rushers. So rushing always, the risk of any kind of accident happens when we rush. So we do need to look at whether or not somebody is constantly having these incidents when they're trying to hurry. And then also some people, especially older people, they fall when they're tired, when they've pushed through too much, and they're really fatigued, their judgment isn't good, their brain is really tired. They can misstep or they can trip on things. So we want to kind of look for patterns. Also, we have to look at our medications, right? So if you've just changed your medication, for example, and the person, starts to have these falls, right? Or if you notice that, the person, when they take the medication after that, they're a bit, it's kind of loopy, or their orientation is different. Those are things that you really want to pay attention to. And then once we can if we can figure out a pattern, so if it is it the rushing that's causing it? Do we think it has something to do with medication? Do we think this is, the falls seem to be always happening at night? The falls seem to be about getting up from their favorite chair. Once we have that information, then we can make a plan about fall prevention based on the pattern that we're seeing. Yeah.
Yeah. So as Debra said, and she keeps saying older persons and persons with dementia, but it can happen with anybody, right? So this is not only about, older persons. It's also you taking a note of what is going on in your environment at any age, right? But yeah, as Debra mentioned, you need to look at things like, is it that when they're getting up from their sofa, is the sofa too low? Do they not have armrests to push up? What is causing this? If they're falling in the bathroom, we mentioned that it's time of day might be an issue. You need to think about things like would a bedside commode be easier for them because they only
Yes.
fall when they go to the bathroom at night? So is it that they can't traverse at night to do that? You know, is it a continence thing? Do they, you know, rush to the bathroom at night because they don't feel the urge and then they rush to get to the bathroom?
Or they wait until the last minutes. A lot of older
Right.
people wait, and that we will say they wait, but also a lot of that honestly is about bladder reflex, as you know.
Right.
You know,
Yeah.
as you get older, sometimes you're not really feeling it until
You don't feel that urge until it's the end, almost
right.
there. Right.
Yeah.
I mean, you know, the truth is there are ways to train it. So, but you have to identify that the problem is there before you can seek training, right?
Yeah.
You know, are they wearing footwear? Do they have supervision at night? And that's one of my favorite topics is that, you know, people think, I don't need a night nurse. What are they going to be there for? I don't need somebody to sleep with me at night. But if you're having difficulties going from the bed to the toilet and there's no bedside commode next to you, that might be the ideal time you need somebody when there's not good lighting and all those other things, you know. And then the other thing to look at is, are the falls occurring only when they're turning? So they're okay if they're going in a straight line, but as soon as you tell them to veer right or veer left, it's trouble, right? Is this a balance issue? Is it that, you know, as we said before, the Parkinson's is calling them to freeze? Is it that they have difficulty moving whatever walking aid they had to go in a circle or on a curve, right? And what's up with their turning technique? Are they losing their balance while turning because the vestibular system is off?
Yes. And also, like with Parkinson's, we know for sure because Parkinson's really makes it extremely difficult. So, like as physios with Parkinson's, a lot of the time we teach them not to like try to pivot because they're too stiff and they're more likely to topple when they pivot. So you might have to teach them to kind of walk in a square. So, you know, instead of you trying to walk at a right angle and then walk at another right angle
And
instead of trying to
another right
spin.
angle. Yeah.
Because particularly for Parkinson's and people who, you know, I'm using Parkinson's because Parkinson's has usually very obvious motor issues, motor stiffness, but also a lot of older people who are simply arthritic or simply just very stiff for various reasons, you know, might have difficulty turning, and you might have to retrain how you turn. But before I chase that rabbit, right, let's get back to the fact that the fall tells a story, because that I think is also important for people to look at. You know, same thing you're talking about when we talk about asking, you know, for the asking person how things happen, like were you in pain, were you trying to get up, what was happening. We also need to, as caregivers, look at where did this fall happen, right? Did it happen in a place where there's a lot of shadow? Did it happen where, you know, it's in a place that's not well lit? Did it happen in a corner of the room or other part of the room where the rug is slightly raised off of the floor? Where did this fall actually? Did it happen coming off of the bed, as we've talked about? Where did the fall actually happen? What was the person doing or trying to do at the time, right? What time of day was it? Which is very, very important. With dementia, we all know about the idea of sundowning and the increased agitation. But it can also be about alertness at different times of day. For example, are you falling when you just wake up? You know, did the fall happen when the person was roused in the morning, etc.? What was the walking aid? If they had a walking aid, was the walking aid being used properly? Was the caregiver there when the fall happened? Again, were we rushing? Did we have, you know, were we able to assess that the person was confused, short of breath, or suffering from confusion? Have we had a medication change, as I mentioned earlier? And have we considered that they might be incubating a new infection? They might be dehydrated, as I've spoken about. They might have had a night of poor sleep. They might, you know, be disoriented or a little bit confused or just groggy from the poor night's sleep that they've had.
Yeah. And I want to add in there too, like check their eyesight as well, right? Because I mean, people's eyesight, especially if you're like a diabetic and, you know, your blood sugar is high, your eyesight might not be as good as if your blood sugar was well controlled at the time, right? So you need to, that's another question I would ask as well.
Yes, yes.
And caregivers, an idea to do is just keep a fall log, a simple fall log. It doesn't have to be anything complex. It just literally needs to be like a notebook where you write down, very often you're taking their blood pressure and their diabetes, their blood sugars every day. You can put if you had a fall or not and a column for that, or just make a note of it. So, and along with what were the circumstances around that, so that you can, and this is data, this is information that you can then share with your doctors, this information you can share with your therapist, and for yourself as well. So as Debra said before, all these falls are occurring as he gets up in the morning. Maybe when we get up in the morning, we need to sit on the bed and chat for 2 minutes or something, just to kind of stabilize yourself before we pop up
Yeah,
and go. Right.
definitely.
So it's information like that. That's crucial.
Yeah. And as we've spoken about, if you're seeing things, if the person is having falls or near falls in the bathroom, that's a message. If it's after nighttime toileting, that's a message. If we're wobbly after the medication, or as Melissa says, when we get up in the morning, that's a message. And we need to, as you say, take the information that you have, and not just sort of say, oh, he's shaking in the morning, but also begin to develop strategies, try to plan so that we're not putting the person in a vulnerable position when we know we have this information. We develop strategies for it. Yeah.
Yeah. Yeah. And a near fall matters too.
Yes.
Because it's telling us that something is building, something is happening. If you notice them grabbing the wall every time, grabbing furniture, catching themselves on the furniture, or they have to be held up by a caregiver more.
Yes.
Yeah.
Yes.
And I mean, you'll see them, don't hold me this way, hold me that way. And they're holding them for dear life. While before, and it could even, because these things happen quickly, right? So it could be yesterday, they were like, I'm good. And now today, right? And these are warning signs, because our health wanes, wax and wanes, right? So you need to be able to say, okay, well, this might have happened, that might have happened. We don't know. We just need to take note of these things so we can add that to our information that we use to provide to the doctors and the caregivers and ourselves to figure out what exactly is happening.
Exactly. I don't think we should wait until we have like a fracture or some kind of emergency. We should be looking proactively for warnings. All of this information we're talking about, all of these early signs, and we want to, when we see them, we take them seriously before they become falls.
Yeah, definitely. All right, now let's move on to the home safety. This is one of the easiest places to start, right? Because many homes have risks that can be easily reduced.
Yes.
Right. As a therapist, I go into homes before patients have surgeries. You go after a patient has had an injury, and when you look at a home and you start walking and seeing what the patients have to do, very often you pick up things that you're like, oh, okay, we need to move this or move that, right? The other thing, the furniture, the mats, the stray mats that are all over. Open the curtains a bit, but I digress. Things that we need to be looking at is, can the person move from the bed to the bathroom easily, right? Can they go from the bedroom to the living room? And all these should be easy activities. It shouldn't take them having to sit down there and be like, can I do this? Would I be able to do this? Things like getting up from a chair, going from the chair to the dining table, right? And what sort of obstacles are in their path. Right. When I say obstacles, I'm looking for things like mats that slide, loose rugs, electrical cords, clutters, small stools. Because a small stool, you might not see it until you hit it, right?
Yeah.
Uneven flooring.
Yes.
Yeah, especially when tiles are starting to blow, poor lighting, pets. Yeah. Wet bathroom floors.
Yeah, because a lot of us now have dogs, like indoor dogs or cats.
Indoor dogs. Yeah. Indoor animals.
Yeah, they can get
underfoot. And it depends on the training too. Yeah, but you could imagine, for the dog who's always been walking by your side, walking through your legs when you were healthy and strong, when you now say to them, no, don't do that, it's very difficult for them to relearn that new pattern, It is. We're looking for things that, like chairs. How low are the chairs? Can they easily get in and out of that chair, right? And it's not only about it being low, but how soft is it? It's more difficult to get off of a soft chair, a soft bed, than it is to get off of a firm chair or a firm bed.
Yes. And I always say the home has to match the person's current ability, not who they were 5 years.
Exactly.
We are very house proud, especially where I am in Jamaica. We like things to be just so. And
Perfect.
sometimes family will say he's always done that. He's always used this step. She's always slept in this room. That rug has always been there. Or I hear a lot. The person they're looking after was always very particular, and so the caregiver wants to keep the home in the way that they would have kept the home, but the person has changed. Their balance, their strength, their vision, their judgment, their reaction time, right? All of those things may have changed. And so we have to understand that the home has to change too. I mean, it becomes...
That's the matching person. Yeah.
Yes, because as we become older, it's less about aesthetics and more about safety and function.
Yeah. Yeah. I mean, absolutely. And I mean, many Caribbean homes, as I said before, have furniture in the way. They don't have a clear path from one place to the other. There's mats, there are decorative items on the flooring, extension cords, because there are not enough sockets in the rooms, and they're not put up neatly. So it's not like they're just in the path.
Yes.
Right. Which is great if you're a strong young person that can see well, right? If you have any impairments at all, whether it be vision, and I also find, and I don't know if it happens a lot in Jamaica as well, but I do know, where people like to have the curtains pulled in the rooms, right?
Yes.
So you walk into the room and it's just dark, right? And you're like, you turn on the light, and they're like, "Why are you turning on the light? I can see perfectly."
Yes.
Like,
and
I can't see, and I have young eyes, so I'm not so sure what you mean about you can see. Yeah, because it's not that they're seeing; they just know the space, right? So they're just maneuvering what they know. Yeah. But if something's there that they're not expecting, they had a grandchild over or something, there's something to trip on, and they're not seeing it.
It's a real problem.
It is. It really is.
It is.
Yeah.
And the lighting is, as you've mentioned there with the dark rooms and so on, lighting is really a big issue. Poor lighting in the day or in the night, because some of our homes are quiet. First of all, a lot of us have these elaborate window treatments, not knocking them, but if they're constantly closed, so that the house, there's very little light and daylight. There's a lot of research that me and Dr. Walcott-Pusey are not going to bore you with about the impact of daylight on the brain, on alertness and orientation and so on. So it really is, light is a big thing, right? So as we talked about it in the day, as I said, a lot of our houses are dark. But especially at night, and we talk a lot in dementia about making sure the pathway to the bathroom, etc., is lit, like having night lights in and so on. But if the person is all the way down if the bathroom rather is all the way down the corridor from the person, right, putting in a night light, and just as Melissa has said, there is a scarcity oftentimes in our homes of outlets. So if you have a corridor, you might not have a lot of plugs, a lot of plug outlets along the corridor for you to put night lights. We might want to consider using lamps instead, and we also want to look at things like motion sensitive light, so that the light is not on all night, keeping all of us awake. It turns on with motion, so that the person can see, and then it dies, so that we don't all have to stay up all night or suffer from that sort of the light. Yeah, the deprivation that happens when you're forced to sleep with light, because our brain works better in terms of our
darkness.
If it has a clear experience of darkness and a clear experience of light, right?
Of light, yeah.
So you might need to consider something else. And night lights, if you can, have a pathway with night lights, great. If not, a really bright lamp or motion sensitive lights. As I've said, clear light switches that are labeled and easy to reach. And that is, that can be a great challenge as well. You can get things like glow in the dark lights, the covers. You can get the dark light covers and so on if people are really struggling.
Right?
And in dementia care, particularly, shadows are a big thing.
Problematic.
The person frequently is going to misread shadows as a person, as a pit. Dark mats, shiny floors can look like holes, or look like they're wet, look like water. It can look like steps for the person.
Right.
So that can make
stepping high.
Yeah, hesitating, stepping badly, and all of that also makes them more fearful.
Yeah. And the other thing is, contrast really, really matters, right? So when you come into a space and everything is white, or everything is, the floor is white, the mats are white, you cannot tell exactly what you're going up against, right? So a little contrast helps. There are lots of ways of doing things. There's tapes that you can put on, just to give you that little contrast of this is where the toilet seat is. You can change the mats if you're having mats in the bathrooms, adding on things like chair rails, just things to help people orient themselves. To know, this is it,
Yeah, definitely. A popular fix in dementia care, and I think it works for a lot of older people, because a lot of us are, not to think, but it needs to be said that a lot of older people are cognitively impaired. So you might not have dementia, but you might have some issue that is below the threshold of a dementia in terms of perception, in terms of your vision, not seeing properly, not hearing properly. Those are also forms of cognitive impairment, right? So when we talk about older people, when I talk about dementia, a lot of these things really can work for a lot of older people, because they are a little bit impaired as well. And a big fix in dementia care, it's so common, you can find it everywhere. Everybody talks about, including me in my videos on YouTube, high contrast toilet seats. So that when the person looks down, the seat and the floor are not the same.
Different colors.
And this is important for a lot of strokes have these issues as well. We'll know that it's because we tend to think of stroke as, they can't walk or they've lost the use of their arm. But you can have perceptual deficit and change with stroke as well.
And a lot of depth perception. A lot of depth perception.
Depth perception, heaven's sake. So
what I've also suggested, the high-res seats are great, but sometimes you just can't find them, or just a little duct tape, put some duct tape on the seat, just around the rim. And then people are like, oh, right, that's, I see. Just something.
Yeah, I have to say, high contrast tape is a savior, and it's usually cheap. In the hardware. And that can just give the person a target, a place to aim for.
Right.
When they're going to sit down, So let's give a room by room check, right? For the bedroom, we've talked about keeping the floor clear, right? We can look at placing our beds at a safe height, and hopefully we'll talk a little bit more about that. When we are going to bed, or when we're going to nap, we need to have our walking aid within reach. So having a
very big one
thing where the walking aid is, I come as a physiotherapist and I'm like, where's the walker? And the walker is all the way across the room from the person, because the caregiver might have, just kind of walked off with it after they seated the person. The person might, for various reasons, want to get up. So their walking aid has to be near to them. Keep a lamp also within reach. If you don't leave on night lights and so on, at least have something that is easily the person can easily reach it from the bed and turn it on. Trailing cords, disorganized cords. I was in a patient's house today, and the amount of things plugged into her power strip and the fan cords, and she needs the cord organizers where you put them all in a so that it's a strap and like a strip, and then you put it, because the amount of cords, that was like an obstacle course to get out of there. And as Melissa has said already, a bedside commode, a lot of our older people don't love them, but a bedside commode, as opposed to you being stuck in Jamaica, it would be Tony Sweet Swing, and in Barbados it might be
hospital. Yeah.
Right? So
Who wants that?
right. So, using a bedside commode as averse to enduring a long hospitalization where you're probably going to have to use a bedside commode, or worse, the
Yep.
bedpan,
Yep.
you have to kind of weigh up those things, in terms of whether or not if the bathroom is too far away at nights, or it's, or in getting there in the night is unsafe for various reasons that we've already talked about, really, really consider using a bedside commode. I think they're underrated as a tool for fall prevention.
Yeah. And I a lot of people, and I mean, a lot of patients have said to me, oh, they don't like the smell. And I'm like, well, just put a little disinfectant in it with a little water, and then you won't have the smell. And then it changes their discourse about it, because I think people just think you just use it like that. But just put a little disinfectant with a little bit of water, so it feels like you're going to the bathroom.
Yes, it does. It really does. That's a great idea. It's a great thing to say.
Yeah. For the bathroom, let's talk about grab bars. Right. And grab bars are not just put it here, put it there. It has to be specific to the patient. So I am a short person. My grab bars and Debra grab bars are going to be at two different heights. If not, I'm going to be like this, trying to get up, because I'm like, I can't, I have no traction. Right.
And also potentially injure yourself. I have a patient that they installed the grab bar at whatever the workman thought was the regulation height. And she is way too short. So in her trying to pull up on the grab bar, she developed a chronic shoulder injury.
Yeah.
You know.
All the time.
Yeah, man.
Yeah. Yeah. So let's talk about things like raised toilet seats. And I prefer the ones with arms. They do have them that are just, something you put without, but the arms help you get in and out. And it also gives you another target, right?
Yes.
All the toiletries within easy reach. I went into a home recently, and whoever constructed the bathroom put the toilet roll so far away that you literally almost have to get up off the toilet to get it, right? So I had to say to them, let's just get one of the stands, so it's right here, so you can literally reach it. But it was like, who did this? Clearly a very tall man. That's all I can say. Clearly a very tall man. Yeah, 1 or 2, right? And avoid things like wet floors, right? So, you need to be able to dry off in the shower before you get out, so you're not bringing all the shower water onto the bathroom floor.
So with you, yes. And drying already. For the living room, remove the loose rugs. Yes, I said it. Jamaica.
There you go.
I said it. You're gonna have to get rid of the loose rugs. All of those rugs that look so pretty, but the end is curling upward.
Curling up.
And all of that, we're gonna have to remove the loose rugs. Reduce the clutter. Yes, we understand about the knickknacks, the things your cousins gave you, all of the wedding pictures. I get it.
Right.
But
Put them up. Put them up as in on a shelf and not on the ground.
Yes. And all of the things that when we are sharing, as a lot of us are in Jamaica, multi-generational houses. So our grandmother's living with her grandchild, and our grandchild has toys. We're gonna have to have a designated place for those toys, and we're gonna have to be more and be vigilant about putting things up after playtime. Because those things, I'm telling you, a Lego, something as simple as a small loose
oh my gosh, I've stood on enough of them to know that is not funny. That will make you hop and fall.
Really cause, it can really cause some serious accidents. We have, all of our older people I've ever met have a favorite chair, right?
Yes.
And that's great. Lots of the armchairs, recliners in Jamaica are very popular, although a lot of them are the wrong heights, right? But we do need to make sure that the chair is comfortable but firm. We don't want to sit down and the older person is sinking into the chair. That's really undesirable. Something I recommend a lot, and it's not very expensive too, are their chair rises. You can usually find that on Amazon that can change
lift
the height.
up, lift up is one of them.
Yeah, a lot of the time when we say, "Oh, that chair is too low," people are like, "Well, what do I do now?" But you do have chair because you've bought this dining set or whatever already, and it's
Yes. Yeah.
you can reinvest now in another set of furniture. Look into things like chair rises so that your chairs are at the right height,
Height for you.
right, as
Yeah.
well. And that also, speaking of chair rises, please do not put the rocking chair on the chair rise. That is unstable.
Yes. Thank you for saying that. It's very important.
So we also need to make sure the chair we're sitting in, that one we had long time where one foot is a little short and it kind of rocks
Yeah.
us.
And it rocking.
Yeah, that's not such
It's
a
not a
good
good
look.
one.
Yeah, not such a good look as we get older. And we're trying
Hmm.
to not have a constant balance experience when we sit down.
Yeah. And that rocking also does a lot on your vestibular system. So you're rocking and you don't need that.
Yes,
You get up feeling very dizzy very
yes,
quickly.
yes,
Yeah.
overstimulated.
All right,
Definitely.
let's get to the stairs. A lot of our houses do have steps in them. And I'm happy that older people are able to do the steps. Always very thankful that they can get up and down. However, let's make them safe. Let's make
Yes.
sure they have good lighting and turn on the lights. It's okay to turn on the lights. Right. Use handrails. And as Deborah said before, good if you know that they're having difficulty with depth perception, or if you even suspect it, just putting on a piece of that high-res tape on each level of the step, make sure that they're definitely safer, right?
Mhm.
Avoid carrying loads on the stairs. I know
Yes.
it's hard. I know it's hard. You don't want to make 10 steps or 10 trips, but sometimes it's better to ask somebody to bring it up for you or make those 10 trips and think of it as getting your steps in, so that you're not having something that may make you fall, or both hands are, you want to be able to hold on to the rail with one hand if you need to and not have the other hand full with so many things that if you feel a little unstable, you can't grab, you
Yes.
know?
Or the weight of the thing causes you to
So
lose
you
balance.
tilt. Yes. Yeah. Do not rush. It's okay to go slower than everybody else. It's okay to say to them, y'all go up first, I'll come behind y'all. Right? Don't let people rush you. Um, right. And ask for supervision if you need it. If you know that stairs are your challenge, or you know that your mother has difficulty going up the stairs and you see her or see your dad attempting to do the stairs, get up and follow them. Just
Mhm.
know that this is their difficult space. So let's
Yeah.
go. Let's walk with them.
And also, I have to say, with dementia as well, some dementias, as we mentioned earlier, they're gonna forget, right? So you might need to have like a
Right.
barrier at the top of the stairs and at the bottom of the stairs, so
At the
that
bottom. Yeah.
if they are beyond the point where they should be attempting the stairs, because dementia is a lot of the time we have to rearrange things onto the ground floor and all of that sort of thing.
Right.
And people may still remember going upstairs and still want to go upstairs
Want
because
to do it. Yeah.
that's where their bedroom used to be. We have to consider using barriers, right?
Mm-hmm.
So
Mm-hmm. Mm-hmm.
putting a chain with a sign hanging on it, using a kitty gate if it is
Kitty gate. Yeah, the
it's
kitty gates are great. Yeah.
if it's strong enough, we need to really consider those things, because nobody wants
Yeah.
to see their
Uh, Loved
parents
one
or
and
go head
yeah.
first down. That's, I think, is one of the most frightening things to watch, even if the person isn't injured, and it's unlikely they won't be.
Exactly.
And
Yeah.
outside the home,
They will change their ability and
yeah,
they'll be fearful of stairs after that, right? Every time
ever
you say
after
stairs,
that,
it's like,
ever
yeah,
after
yeah,
what a fall
yeah.
does to an older person and to their brain, it's not to be underestimated.
Difficult to get it out.
It is very, very
Mm-hmm.
difficult to retrain. And outside the home, we need to think about things like uneven ground, wet
Yeah.
tiles,
Yeah.
a garden hose, steps that
Mm-hmm.
don't have any railings, poor outdoor lighting.
Or those steps that are just a couple of bricks, so they're not stable and no one
Yes,
should be using them.
not us or you, and slippers worn outside, which is always such a crazy thing, especially if your lawn, for example, is uneven. In Jamaica, we have a lot of houses where the lawns slope and do that sort of thing.
Yes.
To be honest,
Yeah.
it's really beautiful when you're young, but really unsuitable as you get older. And you do have to begin to consider things like railings, even outdoor railings. If you're going to stay in a place that has this sort of uneven land surface, it is very, very difficult as you get older.
And then the change of different, like you're walking on a hard ground and then you're going onto the grass. There's a difference in that feeling, especially if you have that grass that sinks. It's like
spongy kind of feeling.
Right. A fall prevention home checklist does not need to be expensive. It actually can be rather inexpensive, right? Some changes cost absolutely nothing. Just seeing that rug and rolling it up, clearing the path, putting all the little trinkets away, all the little things that might cause a problem. In my house, it would be a kettlebell, which, you say you're going to do the exercises with, but it doesn't necessarily get done. But it's right there. Right. You just put it on there and you say, I'm going to use it to hold the door, but the door doesn't get hold. And next thing, there's always something. Yes, I'm going to exercise right next to the mat. You have the two of them there, and then the next thing the mat falls and everybody's tripping. But and no exercise was done.
Oh my goodness. This is why I love having Melissa with me. I mean, it's
the truth.
It's the truth.
So, the truth in my life. But even things like putting your chair in a better position, right? Note that when they're here, this is a dark area in the room. We don't want the chair there. We need to just put it in some place that has better lighting, right? Yes. Look at the lighting, figure out, okay, which is the best place in this room for this to be, or maybe we shouldn't have her sitting here to watch TV. Maybe we need to go somewhere else, right?
Move things around, which is a big battle for a lot of people to sort of to change the home environment. Maybe because it's familiar to them as well, but you do have to. As the person changes, the environment should follow them.
It needs to change. And as Debra kept reminding us, make sure that walker or that walking aid is nearby.
Please.
Right. And another thing that is very important too is things that people use all the time need not to be on the highest shelf. Right. Or they have to climb up to get the
or the lowest. Right. Like to put things
or the lowest, right?
Or these things where you have to be on your tiptoes for it.
And well, for me, that's everything. But I mean, you need to, you literally need to, think about it. And I mean, even because sometimes I'll go into people's homes and you'll see like where they have their toothpaste in the bathroom is out of, and I'm like, okay, like what were we thinking here? To get to the toothpaste, you literally have to go. So like you really have to.
Like a journey.
It's like a quest.
It's like a quest. And then
should I brush my teeth tonight? Yes.
Yeah, keeping things nearby, I think, is the
simple
created piece of advice we can give you is things that you use frequently, place them well, and as Melissa said, keep them nearby. We're on 30. We have a whole lot more to tell you guys, so. I can tell from now, Melissa, we were just talking about what we're gonna do for the live next month, and what we're gonna do for the
finish this.
It's part 2 of the fall prevention. But it's really important. No, it's important that we speak about these things and sort of flesh them out so that people really, you can really feel it in an applied way. Not just to sort of run through and say, this, that, and the other, without people having some examples that they can relate to. The very last thing we're doing this evening is we're going to talk about chair height, because this
it's a big topic.
And this can make a great difference in things like independence, etc. So let's talk about this one practical point, and then we'll wrap it up for this evening and come back and finish up for you guys next month. So let's talk about chair height. I have this discussion with almost every patient that I have.
Everyone, bar none.
It's a serious thing, and I think a lot of us don't take it seriously. Many falls occur in transfers. So when you're moving a person from one surface to another surface, this is a time where you and the person are very vulnerable, and you really want the environment to support you in that, right? Because it means you have to get up, You have to sit back down. You have to move, let's say, from a bed to a chair, or from the chair to the toilet, or from the chair to the wheelchair, from the wheelchair to the toilet, from the sofa, from the wheelchair to the sofa, or from the sofa to standing, which is also a transfer for us as physiotherapists.
Yeah.
A chair can look really comfortable. A lot of my patients, your kids, they're maybe not living with them anymore, and you want to spoil mom and dad, and you get them this gorgeous looking chair that is actually unsafe, So chairs can look really comfortable, but they can also really be really unsafe, especially for an older person or a person living with dementia.
Yes, very true. And a low sofa, even though it is comfortable, is a major problem, right? Because the person sinks into it, and at that point, their knees are higher than their chest, or they're sitting at a funny angle, and then for them to get up, they have to go back into neutral, figure out how they're pushing, and they're pushing on a soft surface, so your hands are sinking in, and you just can't get, and they may not have the muscle power to be able to pop up from that.
Yeah.
Right.
Yeah, and if the chair has no arms.
Right. That's what I was going to say. Yeah, definitely has. If it has no arms, or they have to pull the walker close to them with the it's and they don't want to bother the caregiver, right? So they're trying to grab onto nearby furniture, which is not like stapled down to the ground. So that's moving. You're moving to just try and get up from this sofa. Yeah.
No, and very true. And here's a rule that I really want us all as caregivers to remember. When a person is sitting, the seat should usually allow the bottom, your behind, your buttocks, your backside, whatever you want to call it, right? It should allow your bottom to be level or slightly higher than your knees. I'm going to say that again. When a person is sitting, the seat should allow the person's bottom to be level with or slightly higher than the knees. If the bottom is lower than the knees, it is going to give the person a lot of work. They have to work much harder to get up. And they have to generate a whole lot of force through their joints, through their hips, their knees, their thighs, and sometimes their spine as well. For an older person or anyone, for an older person, a stroke, a younger person with illness, or somebody who's post-operative, with weakness, with pain, with arthritis, with a stroke, with frailty, with back problems, this is definitely 100% of the time, 100% of the days of the year, it is going to increase your risk of having a fall.
Yeah. And it also makes the caregivers have to pull more or provide more force to get you up out of that chair, right? And what I find happens most often is because they're pulling and they want to get a good grip, you'll see them go directly under the arms and tug at the arms just to get them going, right?
Yeah.
The problem with that, right, is that you can hurt your shoulder. And so you can end up with people who have stroke, especially if it's a stroke patient, you can dislocate the shoulder if it's a stroke patient. But just a normal person, you're tugging on that shoulder, all of a sudden now they have shoulder pain. And then that makes it even more difficult for you to get them out and up the chair. They don't want to sit, they don't want to do things. It causes them to not want to be active part of what's happening in their house, right? And it will throw the person off balance.
And you too. So oftentimes the person doing that.
Right. Right. Or they will be resistant to or they become resistant to the pull. So anytime you go to say to them, we're going to move you now, they're like, no, and they're fighting you instead of coming into and you assisting you in them.
It is important. So let's talk about what we call a safe for us as physios. From getting up from sitting, we call it sit to stand, right? So you're all honorary physios now. So let's talk about a safer sit to stand, right? The chair has to be stable. It must be stable. Yes. It has to be stable. If it's sliding, if it's slipping and sliding out of place, that is not a stable chair. And that is a simple fix. Let me spoil it for you. Usually, if you get just a simple gym exercise mat and cut it and place it under the chair, if you have like a lot of tile on your floors and stuff, just a simple fix like that sometimes can make it a lot less slippy and slidey, right? But make sure the very first thing you know, so you can try that if you if you have those kind of which I hope you don't, those tiles that look like they're like glass, water, beautiful tiles. They're beautiful until you have a gorgeous who thinks that they're water, who thinks that they're stepping into water, or until they are resistant. Yeah, they don't want to go on it, or they're so slick that every chair is sliding around the place, and it's like an informal ice rink. So if you find yourself in that position, cut up a gym mat, stick it under the chairs, and see if that helps, because the chair should be stable, right? We would like for someone who is not able to stand independently. All physios are gonna tell you we love chairs that have arms. If it is at all possible, a chair should have arms. The person, when they're trying to get up, they should not be all the way at the back of the chair trying to get up. We want to have the person moving closer to the front of the chair. I usually tell them sit halfway up the chair cushion at least, or move your bottom towards the front of the chair, right? So, but not so far, because some of us are not, I want to say we don't have good control of our trunk, right? So sometimes when you sit too far forward and you're not really able to control your trunk, it's also dangerous for the caregiver, because then they're at risk of sliding off the chair, right? You want to make sure when you are sitting in a chair that your feet, especially for stroke, but also for any other neurological condition, you really want to have your feet placed on the floor and slightly behind. Your ankle should just be slightly behind your knees. If you look at yourself when you're trying to get up, your feet, you kind of have to brace on your feet, as Jamaicans would say. You kind of have to brace. So you bring your ankles slightly back behind your knees so that you can brace. You get more force and you're able to stand more easily. Right? There is a video somewhere on my YouTube about nose over toes. Which is a big thing. And we mentioned very briefly about retropulsion earlier, the tendency a lot of older people have to really try to lean back when they're standing, which is just like a super unsuccessful strategy. We want to, and there are ways to revert, there are ways to work with retropulsion. But you really want to encourage the person to lean forward as far as they can. Nose over toes is a good landmark. You want them to at least get around the area of their knees. I'm sorry, I'm leaning forward myself because I'm so accustomed to giving this instruction. So you're going to lean forward, your nose over toes, your hands on the arms of the chair. You're going to push from the arms of the chair and press through your legs to stand up. Okay.
I mean, the thing, it sounds like it might be a bit complex. If by any chance you're a bit nervous about it and you're not comfortable, call your physiotherapist. That's what they're there for. They can do a session. They can help you get that strength back in. And sometimes when you have that doubt, it's better to talk to somebody who can say to you, at this point, this may not be a good move for this person. We need to do a little bit more strengthening, or we may have to modify it another way. But that's our jobs.
Yeah,
so we're here to help.
To work technique, because I think a lot of people really don't understand that when you are gonna stand up, there is no strategy for standing up. You don't, none of us, whether or not we consciously feel it. A lot of us, we don't. You stand up in a particular way every time, right?
Yeah, muscle memory.
And sometimes people need to be re-educated on how to stand up, right? So when we talk about sitting to the front of the chair, make the chair is the right height, it's stable, it's not sliding. You're not trying to get up from the back of the chair, always a disaster because it generates a lot of force. And then you're leaning forward, pressing to your legs and your hands to get yourself up out of the chair. A lot of older people, for various reasons that have to do with their brain, I cannot say enough about retropulsion. Like if you've been lying down a lot and your brain has reset where center is, so that your back to get up, or if you've had more than one fall and your brain, whether or not you have it, because people say, but they have a dementia, they can't really. Yes, your brain, even in a dementia, if you have had a series of falls, your brain is not going to want to get up, and it is going to resist getting up, even if they have a dementia. I can't say this enough, because a lot of us, we think, oh, but they fall, but they must have forgotten that your brain,
they remember that,
and it means always to protect you. So whether or not you consciously remember, your brain has recorded that as an incident it wants to avoid, and it is going to fight you if it does not want to get up. Even if the person is trying to be willing, once they've had that repeated experience, the brain itself is
the fear of falling.
It's just gonna it's just gonna resist.
There.
But let you go through the sequence.
But once you're standing, there should always be a pause before you step away. A pause just to reorient yourself, to let your body know, I'm upright. We can go now.
And also,
am I dizzy? Right. Yeah. So let people remember, am I dizzy? And if you are, what do I need to do from here? Do I need to sit back down, or just stay here for a minute and it'll pass, right? You need to take that into consideration. So the sequence becomes feet flat. You're leaning forward. So this is where your nose over toes comes from. You're pushing up, whether you're using your hands for assistance or just your legs. Stand up tall and pause. Once you're not dizzy, once you're feeling well, then you can start moving.
Right. And when sitting down, now that we've covered standing up, when sitting down, you want to make sure that the person you're working with, and even you yourself, should feel the chair behind your legs.
Your legs. Must feel that chair.
Yeah, please. Because, especially if your chair is, you don't want to sit under any circumstances. No one of any age wants to sit, and the chair is not where you thought the surface you're trying to sit is not where you thought it was. So you want to feel it with the back of your legs first. Then you want to reach for the chair, reach back if it's possible, reach for the handle of the chair, and sit down slowly. A lot of my patients spend a lot of time practicing at like a count of 5 as we sit down, because they love to just drop down into the chair, just as you said. You don't want to be dropping into the chair. And confidence, if they're lacking control, and confidence is not something that you can just, I think when we say, confidence is a physiotherapist problem, people are like, oh, really? But it is, because to relearn in an environment that is supportive and safe, you have to learn how to sit and stand safely. And that's, we are trained to do that. That is, our wheelhouse as a physiotherapist. Well, as physiotherapists.
And I mean, we as physiotherapists, and we also know what strengthening exercises to give them. So it might, and I mean, I've seen people say, oh, but it has to be their glutes, or, they're not firing enough, or it has to be this, but it might not be that they're not firing enough. It might be the coordination between this muscle and that muscle group to be able to get this done, right? Maybe your core strength, that's not, so as you're going down, the abs are like, nope, can't take this. And so, blam, don't
when we're trying to move.
Right. So the caregiver needs to take note of these things, right? You need to see what's happening and maybe try a couple of things, like talk to the therapist about strengthening, try a different chair, right? Or maybe you need to do closer supervision and see, because you might try a different chair and realize that, okay, they can get out of the dining room chair really easy, but that sofa just can't get out of that. So what's the difference? The sofa is soft, the dining room chair tends to have a bit more stability, so let's work with whatever it is, right? And remember, the toilet is another type of chair. Right. So, we talked about the fact that you may need rails. You talked about the fact that, you may need a seat riser. So look into these things and take note. Take note of when they're having difficulties, so that you can find the reasons and find things to correct the difficulties.
All right. So we're going to leave it. This is where we wrap up for this evening. We have a lot more to go through. And the first thing we're going to start with next month end is going to be the bathroom, which is a big sore point, and also the use of walking aids, which I don't think me and Melissa can ever say enough about.
Ever stop talking about.
Appropriate, safe use of walking aids. I don't think we're ever going to stop talking about that on Caregivers, because that is another thing that can really multiply your fall risk, and a lot of you just don't really understand that. So we're going to wrap it up for this part one. I'm personally kind of thrilled that we're going to have a part two. I love having Melissa with me, and as I said, she's going to continue to be a co-host. And we will bring you part two at the end of next month. So this is the end of May. We'll bring you part two at the end of June. And you get to look out in the community and also on the social media, both mine and Melissa's. Please follow Melissa. She is Total Therapy, and she has a whole lot of fantastic physiotherapy advice that she gives you while she's taking notes. And she explains a lot of stuff to you that you really do need to know. I think she's more than a worthwhile follow. Please give us your social media handles and so that people can
so we can follow you as well.
Yes.
For sure. Oh, it's Total Therapy 246. Yeah. It's like, what, me? Total Therapy 246. And that's everything. You'll find it.
You find it on
Instagram, everything.
And that is 246 is Barbados' area code. So
area code,
246. Look out for it. Just so we're 876 is 246. Look for it and follow her, because as I said, she has a lot of really, really excellent advice. Melissa is a very, very experienced physiotherapist. And where I have kind of specialized out of things like orthopedics, Melissa is still very
much a lot of it.
Very much an orthopedic physiotherapist in addition to the neurology. She's just excellent. So give her a
follow. Your brain controls everything.
Yeah, your brain does.
So you know.
That's why I specialize out in neuro, because I realize the brain is the center of everything for me.
It controls everything.
Yeah, and I have a short attention span, so I cannot do another total knee. I just can't. So we leave it here for this week. Please look in the community. We did a lot of, last week we had safety as a theme. So there are a lot of handouts about home safety. I have a home checklist where you can go from room to room yourself with the printed checklist and tick off the rooms and assess them for safety and so on. Home safety and fall prevention are related topics. At the end of this, so between this month and next month, we'll probably pop out some more handouts on fall prevention more specifically. But please look at the community handouts on safety. There would have been a notice last week that talks about those and links them so that you can find them easily in what I call the library and what is in the community called the classroom. So thank you, everybody who's going to see this, everybody who came tonight. I didn't get to acknowledge Jackie Ovadia came through earlier as well. Thank you for everybody who came to hang out with us. And we hope you come back next month to hang out with us again. And you see this will be posted on the Caregivers YouTube channel, and you will be notified of that so that you can, for those of you who had to jump out or come back in for various reasons, you can catch the entire live. I post it unedited on YouTube as well. So Melissa, thank you so much for being with me tonight. See you next month. See everybody next month.
For sure.
We wrap up part 2 of this fall prevention session.
This one.
All right, guys.
Have a good one, Debs.
Bye.
Bye.